Hello, I'm Dr. Nora Hansen, Director of the Lynn Sage Comprehensive Breast Program at the Prentice Women's Hospital and Associate Professor of Surgery at the Feinberg School of Medicine. If you are diagnosed with a breast cancer, you want to know what your surgical options are. Part of it depends on the size of the tumor and the location of the tumor, but basically there are two options. One is called breast conservation, where the purpose is to preserve the breast and leave you with a normal-looking breast, and the other option is to remove the breast or a mastectomy. And part of the options will depend, again, on the size of the tumor and the relationship to the size of your breast. Probably the most common type of surgery now performed today is breast conservation, and that consists of removing the lump with a normal room of tissue, and then depending on whether or not you have an invasive cancer or a non-invasive cancer, we may need to check the lymph nodes and do what's called a sentinel node biopsy. If you have an invasive cancer, that means that the tumor has the potential to spread. We don't have a good blood test to check if the tumor has spread, and so what we do is we check the lymph nodes, since breast cancer can spread either through the bloodstream or through the lymphatic system. So a sentinel node biopsy is a method we have to detect the first lymph node that has the highest chance of having tumor cells. If that lymph node is negative, then you don't need to have the rest of your lymph nodes removed. If that lymph node does have some tumor cells, then the standard is usually that we remove 2 levels of lymph nodes, but there are some circumstances where even if your lymph node is positive, you don't need to have all the lymph nodes removed. And it's really for those patients who are undergoing a breast conserving procedure who have less than 3 positive nodes. So that would be something to talk to your doctor about, whether or not, even if your lymph node is positive, do you need to have all your lymph nodes removed. When you do breast conservation, you have to undergo radiation therapy, because if you just remove the tumor or the lump, the risk of it coming back is about 40%. But with radiation, the risk of recurrence goes down to about 5 to 8%. So if you're having breast conservation, it is very important that you undergo radiation therapy as part of your treatment. The other option is to remove the breast, and that's called a mastectomy. And there are several different kinds of mastectomies. A modified radical mastectomy would remove the breast and the lymph nodes. A skin-sparing mastectomy would preserve most of the skin, except your nipple and areolar complex would be removed. In that type of surgery, you would have immediate reconstruction at the same time. And now the newer option would be a nipple-sparing mastectomy, where you leave the entire skin envelope and preserve the nipple and areolar complex. This would afford you the best cosmetic outcome, but not all patients are candidates for a nipple-sparing mastectomy. The best time to talk to a plastic surgeon regarding reconstruction is before you've had the surgery in terms of your breast cancer. So once you're diagnosed with breast cancer, if you think that you're interested in a mastectomy, then you should ask your doctor to refer you to a plastic surgeon, because the best time for the reconstruction is at the time of the breast cancer surgery, and that's known as immediate breast reconstruction. That affords the surgeon, the breast cancer surgeon, the ability to save most of your skin. The plastic surgeon would then come in at the time of surgery and either put an expander or an implant type of reconstruction in, or they would take tissue from your body, such as your abdomen or your back, and use what's called autologous tissue and reconstruct the breast at the same time. Now, there are some centers that do not promote immediate breast reconstruction for those patients that may require postoperative radiation therapy. At the Lynn Sage Comprehensive Breast Center, we are really proponents of immediate breast reconstruction, and except for patients with inflammatory breast cancer, we do recommend immediate reconstruction at the same time. So we would have you see the plastic surgeon at the time of close to your initial consultation, so that we could coordinate your care with the plastic surgeon at the time of your initial surgery. Patients are often concerned about the risk of lymphedema regarding breast surgery, and there is a definite risk of lymphedema anytime you either remove the breast or the lymph nodes. The sentinel node biopsy has really been a way to reduce the risk of lymphedema, and if you only have a sentinel node biopsy, your risk of lymphedema is less than 5%. If you have to have an axillary dissection, your risk of lymphedema probably goes up to about 15%. However, with aggressive physical therapy, we can try to reduce that risk of lymphedema. If you're having a mastectomy, just by removing the breast, you are at risk for lymphedema. However, there are things that we can do to help reduce that risk. And I think getting a patient involved in physical therapy very soon after surgery does help reduce the risk, and educating the patient on what the risk factors are is also very important. The type of surgery that one would choose in terms of treating their breast cancer, whether or not it be breast conservation or mastectomy, will have an impact on the length of time that you need to be in the hospital or away from work. For example, if you end up choosing breast conservation, it's usually an outpatient procedure. So you go home the same day, you do not need to be hospitalized overnight. You're sore for about 2 weeks, and usually you can return to work within 2 to 3 weeks. If you have a mastectomy with reconstruction, that is a bigger operation, and therefore we usually keep you in the hospital 1 or 2 nights, depending on the type of reconstruction that you do. I think you have to plan on being out of work for about a month if you undergo a mastectomy with some type of reconstruction.